going to now hear from two people who are really integral to what's going on in Philadelphia. And so I would like to introduce first Jackie Kendrick, LCSW, who serves as the Violence Prevention Supervisor for CHOP's Violence Intervention Program, which provides trauma-informed case management services to violently injured youth and their families. Jackie has worked extensively with children, adolescents, and their families in a variety of community and site-based settings, including child welfare agencies, community outreach and training, behavioral health, early intervention, and autism services. Jackie received her Bachelor of Science in Human Sciences with a minor in Disability Studies from the University of Delaware and her Master of Science in Social Work from Columbia University, where her focus at that time was on advanced clinical practice with a concentration in health, mental health, and disabilities. Jody Thigpen is the co-presenter, and she's an LCSW. She serves as Violence Prevention Specialist also for the CHOP Violence Intervention Program, part of CHOP's Center for Violence Prevention. Jody provides support to youth who have experienced a violent incident with intensive case management services for that youth and their families who have come through the emergency department. She is also trained in trauma-focused cognitive behavioral therapy and child and family traumatic stress intervention. She also provides therapy to youth healing from their traumatic experiences. Through case management and therapy, she supports families navigating complex systems, connecting them to essential resources, and progressing in their healing process. Jody's past experience includes working in educational settings, supporting the academic and emotional needs of youth. She is passionate about supporting youth who have experienced trauma and advocating for social justice. Jody obtained her MSW at UPenn at the University of Pennsylvania and a BA in psychology at UC Santa Barbara. And so now I'm going to turn the slide presentation and we all turn our attention to both Jackie and Jody.
Hi, good morning, everybody. All right, so thank you so much, Elaine, for that introduction. And today we are going to talk about CHOP's Violence Intervention Program, the structure of our program, and then provide details about each component. So we're going to start with a brief overview about trauma, then provide a summary of CHOP's VIP program overall, before going into detail about the two components of our program. And then we're going to finish with a discussion about the challenges in our work and how to incorporate self-care into the team culture. So what is trauma? There is no one-size-fits-all definition for trauma, as we define trauma according to an individual's unique response to a particular event. The same event, such as a motor vehicle accident, may be distressing and traumatic for some rather than others. But as you can see, there are some themes that cut across expert definition of trauma as a construct. So trauma is an event that overwhelms and dysregulates our neuropsychological and cognitive functioning such that a person is unable to optimally utilize resources and coping skills. So trauma is an injury to the brain that is emotionally painful and distressing. It is a subjective experience based upon many factors such as age, gender, societal standing, and race. If untreated, trauma can lead to a host of negative outcomes like co-occurring behavioral issues, problems in school, involvement in the justice system, involvement in community violence, or engagement in risky behaviors as a form of coping. So knowing all of this, it's our program's goal to interrupt that cycle of trauma and negative outcomes. So I always like to show this slide because I think it does a good job of showing what we see clinically. So many of our youth are having nightmares and trouble sleeping. They're having anxiety or depression. They have increased anger. Some are self-medicating with drugs and alcohol, and a large percentage of them suffer from daily migraines. But the positive news is that there are resources available to help our youth heal, and it takes a collaborative effort of multiple systems that interact with youth and families. So as social workers, we are trained to look at the biological as well as the psychosocial effects of trauma. And so in order to address this pervasive issue, we have developed a holistic approach in treating individuals. So trauma comes in many forms, whether it is an acute traumatic episode, a major life event, or environmental stressors, of which the majority of our clients and their families experience regularly. So these environmental stressors are often a result of structural racism, a system of structuring opportunity and assigning value based on race that unfairly disadvantages some individuals and communities and advantages others. We see this playing out all the time, all too often with our clients, for whom traumatizing events are a result of the zip code they live in. And unfortunately, research now shows that our zip code matters more than our genetic code in determining risk for long-term psychosocial outcomes. Now I'm going to turn it over to Jody to give you an overview of what CHOP VIP does to support our youth and families in Philadelphia.
Hello, everyone. Yes, thank you. Now moving into what exactly our program looks like and how we've structured our services. So here in the Violence Intervention Program at Children's Hospital of Philadelphia, we provide client-centered, family-focused, trauma-informed intervention services for assault-injured youth and their families during and after a hospital visit to promote physical and emotional healing and prevent re-injury. So we combine trauma-focused case management services with our trauma therapy services, which we'll get more details into that shortly. But youth are referred to our program from either the emergency department here at CHOP, our trauma unit, our concussion clinic, or sometimes even a community hospital in the area. And I do want to note that pre-pandemic, most of the youth we were seeing were referred to us with blunt injuries such as concussions, and often either assaulted in school or around school. And sadly, obviously, with children not in school or in person, mostly in school, we're seeing more community violence and sadly more gunshot wound injuries for our youth and families. Next slide. Yeah. So why are violence intervention programs needed? Nationally, 300,000 youth seek ED care for violence-related injuries. And oftentimes, our patients don't seek ongoing services following their injury and are at risk for post-traumatic stress. With our violence intervention program, we're able to meet families in the hospital when they're often interacting with many systems during an overwhelming time, and we can help make those connections to services and facilitate any barriers that come up. So as I said, we meet families in the hospital and provide that bridge to community support. We address the needs of both the youth who have been injured as well as their family members and take that holistic approach of meeting the needs of the whole family and allowing the family to have voice and choice in identifying their needs. And as I said, navigating the barriers that come up to help families engage in services so that they have those long-going supports to promote healing, to promote their well-being. And just a little more details about the youth in our program. As I mentioned, obviously violently injured youth, they have to be Philadelphia residents for our program. They're 8 to 18 years old. 70% reside in West and Southwest Philadelphia, which are the areas closest to Children's Hospital. Average age is 14 years old. 82% are African American. We actually see equal numbers of male and female teenagers and youth in our program. And pre-pandemic, 70% of assaults were occurring in school or around school. As I mentioned, this number is different now with many of our youth suffering from gunshot wounds. All right.
Okay. So now that we've provided an overview of trauma and what really drives our work, as well as a broad look at VIP, we really wanted to get into the nitty-gritty of each of our core components. So the first component that we're going to talk about is our trauma-informed case management. Our trauma-informed case management is delivered by our violence prevention specialists, who are all trained social workers. So whether it's at bedside, initial outreach, or intake, psychoeducation is really at the foundation of our service delivery. We provide education about symptoms of trauma and interventions that can help. We really want to normalize what our kids and families are feeling and going through so that they don't feel so out of control or that they don't feel like they're going crazy. We listen to the parent, patient, and caregiver and validate and again, normalize their experience. We explain our program and how we can help navigate the different systems they now find themselves involved with as a result of the assault. And we really, on that, our main focus of that initial encounter, as Joel had mentioned in the previous talk, is to address that family safety, both physical and emotional, as well as address those concrete needs. We look to see how we can provide something immediately and support immediately, whether that is providing transportation home, providing food because they're having some food insecurity, providing clothing. We want to make sure that we're meeting those immediate needs. Not only do we get buy-in, but also we recognize that our families are really overwhelmed after an assault, and we want to make sure that they're not necessarily having to worry about having food or clothing or a safe place to live. So our intake and needs assessment is very comprehensive. And on the next slide, we'll go into each of the intake domains. But this assessment helps lead to the identification of goals. We have learned that an injury event does normally lead to certain goals like medical follow-up, police advocacy, legal advocacy, and safety planning. And through conversations, we can offer relief and build relationships to help address these goals and others as they emerge. So using a trauma-informed approach, we understand that a family has likely experienced a traumatic event, but has also likely have a longer history of trauma. So we want to make sure that their voice and choice is paramount, and we're giving them as much control in this process as necessary. So we don't go in and say, this is what you need to do, or this is what you should be doing. We really say, this is everything that we can help with. What are the things that seem like you would like support with? So if a family is not interested in therapy, we're not making that referral. If they would rather manage the legal system on their own or are not interested in pursuing any kind of charges, then that is their choice and we support them in that. Again, it is all about that voice and choice of our youth and family. We also take a family approach. So not only are we addressing needs of the caregiver, but we take some time to speak solely with the youth and helping identify their own needs, which may be different from the caregiver, such as working papers or extracurricular activities. And then we also address the needs of the entire family. So if a sibling needs support in school or needs support with mental health services, we work with a caregiver to connect that sibling. We find that having these conversations, not only with the caregiver, but really with the youth, it helps enhance engagement in our services. So as I said, we ask a lot of questions that provide us information, but it also helps guide us through conversation. That information helps guide us through the conversation. So we strive for an intake to feel like a supportive conversation rather than kind of sitting through with a form and checking off boxes or asking a series of intrusive questions. The questions we ask are helpful in setting goals together, but they also inform the family about different areas of support that we can provide. So if down the line they feel more comfortable bringing up therapy or food security, they know that that's something that they can help with. And we find that some of our families, it takes, and rightfully so, takes some time for them to trust us. So if they know that these are things that we can help with and aren't ready to talk about it, they can feel comfortable bringing it up later on. So these are our intake domains. The first is general. So, contact information. Do you prefer us to text or call you? What are the emergency contacts if needed? How would you like us to identify you? all your basic demographic information. If we have this information already based on the referral, we're just verifying it. We're not trying to make the processes least intrusive as possible. So we're not asking them to answer questions that we already know the answers to. We're just verifying it. And then safety. So we're asking about threats in the community, concerns that they have, if there's police involvement already, and if there's school concerns, because like Jody had said, prior to the pandemic, a lot of our injuries were as a result of an altercation either before, after, or during school. So a lot of our safety planning is done with school personnel to ensure the safety of our kids in those buildings. Education, so what supports or accommodations are already in place and what supports may need to be added. This gives us an idea of where to go in advocating for that extra assistance that our kids might need following an injury. We collect medical information, one, not only to understand what necessary follow-up is needed after the violent injury, whether that's the concussion clinic or physical therapy or wound care or trauma follow-up. We also ask about unrelated ongoing medical issues because sometimes our families need help managing those ongoing medical concerns. We talk about mental health. So we ask if they have ever been connected to a previous mental health provider and what was their experience with that. If they're not currently connected, are they interested in getting connected again? And also, we want to know about their current mental health standing. We ask about legal. So have they filed a police report? Are they interested in filing a police report? Do they need help getting the DC number or do they have it? Do they have the detective's name? We're happy to call and get that for them. Are they interested in filing a private criminal complaint? And again, throughout all these domains, we're also providing psychoeducation. So we'll let them know what the difference is between a police report and a private criminal complaint and what might be the best route for them to go so that they have all the information they need to make those decisions. We see if there's any court dates that are coming up. If the child is already involved in the juvenile justice system, do they need help with advocacy in that system? And then housing. Housing is an important domain for us to know because a lot of times relocation is a goal for our families, and that can look different based on if they own the house, if they rent, if they're a part of PHA, Philadelphia Housing Authority, who lives with them. Do they have other needs, concrete needs that relate to housing like furniture or utility assistance? And again, we're asking a lot of these questions in hopes to understand the family's need, but also give them an idea of what we could support with down the line. And then finally, we're asking about the youth well-being. So this is mental and emotional help. What support systems do they have in their lives? Are they involved in extracurricular activities? Are there things that they're looking forward into the future? Are there things that we can help facilitate access to? So I know that was a lot of information, so I'm not sure if there's any questions about our intake domain. So I just want to pause before we go into Jody starts talking about goals and example goals.
Jackie, there's a question that says, do you involve other family members or siblings?
Yes, oftentimes it's in the intake process. Sometimes our families come with siblings or other family members. So depending on the age and the appropriateness of talking about the circumstance in front of that child, we may involve them. If we are asked about needs or services for a family member or another sibling, we may set up a time to talk to that sibling as well to get their input and their impression, especially for mental health needs. If that child is over the age of 14, getting an idea of what they want out of services is definitely important. Another component of our program, which we'll go into a little bit later, is our peer-led psychoeducation group, and we always invite siblings to that group as well. I'm going to turn it over to Jody now to talk about some of the goals that come up with our families and what the examples are and possible resolutions.
Through all of those questions, through that conversation of meeting with families during the intake, we're able to kind of talk through goals to work on together. And again, that's led by the family. We help out with what the family wants our help with. So that's going to look different for every family, how kind of intense or involved our services are. For some families, they just may need a couple referrals and some guidance around navigating systems. For some families, we're attending multiple appointments, helping with transportation, getting them access to things like food and housing support. So it's definitely a range of goals and services that we're working on together with families. We don't have a set number of visits or requirements that we do with each family. It's sort of on a case-by-case basis of what the family needs or wants from us. But here are some examples of kind of what those domains and talking through them, how those translate into the goals that we're actually working on, whether that's referring a youth or family member to therapy, as we kind of talked about, coordinating a 504 plan in school, which is supports likely related to their injury or concussion, like a check-in with a counselor or extra breaks during classes, really assessing for safety, whether that's setting up a mediation, or unfortunately, a lot of our youth are experiencing suicidal ideation. So helping navigate that either with referring to crisis or creating a safety plan, basic needs like food and housing support, navigating the legal system by advocacy, going to court with families. And a lot of our youth want to get jobs or apply for working papers. So like I said, that based on the family's wants and needs, both for the youth and for siblings and the parents, we're kind of navigating these goals together with them. And these are often identified at intake, but it's not like we meet a family, we identify goals, and that's all we work on. A lot of times as we build trust with families during our work together, more goals come up along the way. So we are always open to, as the family needs our support or wants our support, if more goals come up during our time together, we still open those and address them with the family. And so what needs are actually being identified while working with families. And so these are our top domains: mental health, legal education, the psychoeducational groups, and safety. And you'll see that actually mental health is most often identified at almost 90% of our families, identifying some sort of mental health need to work on together during our work with them. And once a need is identified, thinking about what success looks like. So for each of our needs and our goals that we're working on with families, we have kind of our idea of ideal outcomes where we can resolve those. So if wanting to participate in our peer group is a need, when they've actually attended 50% of our group, that would be a resolved or successful need with attending group. If they need medical care, attending their follow-up appointment, legal assistance navigation, attending court. Again, school advocacy, creating a 504 plan with the family. So, and as next slide. With resolving our goals, with intensive case management, meeting families where they're at, navigating the barriers that come up and finding ways to address those, we're actually able to have a very high success rate of resolving needs identified by the family, with 72% being met throughout our time with families. Any specific questions about the goals working on with families?
I'm very interested in learning more about your data management program. So at CHOP VIP, we have part of our team is a research arm. And so we do work very closely with our research department in studying outcomes for our children. Part of our intake, we do collect measures, and we look at pre and post measures for our kids to see if we have reduced trauma symptoms. So we use CPSS, which is the Child PTSD symptom rating scale. And then we use the RCADS as well, which is the revised Child and Adolescent Anxiety and Depression scale. to see, one, that not only gives us information to see how our youth are handling their trauma and how they're processing it, it also gives us an idea of what we can do to support them. And it also looks at if the combination of trauma-informed mental health services and trauma case management do decrease both of those scores. We also ask the caregiver to complete those measures too, in relation to how they view their child or is coping with the trauma. So not only do we get the child self-report, we get the parent's report on the child. And then we look to see if the work that we did decreased those symptoms. The programs that we use for data management, I think that probably that is a question that Joel might be better to answer as the social worker. We use a program called Question to import and document all of our data. That kind of behind the scenes data management is something that I'm not necessarily involved in the day-to-day, but it is definitely something that we could talk more about.
And that Question program was developed actually through Michelle's group in UCSF with the input of frontline workers. But a lot of people are using other programs as well, so it's not the only one out there.
And so before we move into the trauma-focused mental health services arm of our program, I'd really like to just take some time to answer anything about our trauma-informed case management, because I do think that component, we reviewed it pretty quickly, and it is, the major core of our program. Will you be addressing the ambassador program that was part of the CHOP program? I'm not sure, Elaine, what you are referring to.
Several years ago, we had a very interesting program through what you all were doing back then, and you had some youth who were ambassadors who actually were kids who had experienced violence themselves, trauma themselves, and they went through programs with you. I just wondered if that was still something that was happening.
Elaine, I think you may be talking about our group work, people who've gone through the program who are actually peer mentors, and they will be talking about that.
Thank you.
Sure. And I think what's really important about our trauma-informed case management, and we said it multiple times, is how that it's not a mandatory program. It is not, there is not a set number of visits. There's not a set number of goals. We really work to meet the family where they are at. There isn't an expectation that they come to us. We see them in the community. We go to their homes. We meet them at their doctor's appointments, or even pick them up and drive them to their doctor's appointments. We meet them in the school, at the mental health community center. We really want to reduce as many barriers to engagement in services as we can. We also recognize that a lot of systems and programs that have been involved in our youth and families' life have not always done what they have been designed to do, which is support the resiliency and recovery of our families. And so at times we have an uphill battle that we have to show up for our families and actually do what we say. And that is why, at first meet, we really try to see if we can tackle some of those concrete goals. So that, you said you need food, we can point you in the direction of a food bank, but we can also have food delivered directly to your house, and then work on a long-term goal and to address food insecurity. So those things, you aren't able to go back to your home right away because it's not safe. And so you didn't have a chance to go back and get your clothes. We're not going to necessarily send you, wait for Cradles to Crowns, which is an organization that helps with clothing. We're going to maybe give you a Walmart gift card or a Target gift card to get clothes right away. And then we can address some of those long-term needs. So those are the things that we make sure when we're budgeting to have those discretionary funds so that we can support a family in real time and not necessarily have to go through some of the red tape that other programs may have to deal with. Sure, I can talk more about the considerations in designing a safety plan. So one of the components, and Jody, feel free to jump in here because Jody does this work every day, is talking about safety. So we ask very specific questions: is do you feel that the altercation that led to the assault is resolved? Yes or no. We talk about, do you feel safe leaving the hospital? Did you feel safe leaving the hospital if we've talked to them after they left? Do you feel like you would retaliate or do something to the people that hurt you? Do you feel like your family members? So we get all of that information. And then if there is, like at times, if there is a very specific retaliation plan with time, location, like we do have that duty to warn, but oftentimes what we see is our kids are really angry and their families are really angry about what happened, and they just need someone to listen to, and they just need us to validate that their anger is real. When it comes down to logistically planning for safety, we do talk about, like, where can you go if it's not safe in your community right now? Do you have other family members that you can stay with for the time being? What is your plan if you feel like your safety is being threatened? And we go through those concrete steps. Jody, do you want to jump in and maybe talk about an example or talk more in detail about the safety plan regarding retaliation?
Yeah, I was gonna just add in that I feel like doing this work is so much about the relationships built with the youth and family that the conversation around retaliation looks very different at intake versus maybe a month later after you've helped a youth get to their appointments and sat there at the doctor's visit for an hour talking through how they're feeling, actually getting them connected to resources. And oftentimes then, as you build the relationship, is when you're able to have a more trusting and in-depth conversation around what the concerns are, what the worries are. And like Jackie said, it's often about just the anger that the youth is feeling, and when they're connected to support, whether that be mental health treatment, whether that be individual therapy, or our group where they're around other youth who have experienced something very similar, whether they're connected to physical therapy and can start getting some of their movement back if they have a more serious injury. We find that that initial anger right after the injury, I think, is what's often driving the retaliation. So if we can build that relationship and get them connected to the right support, that risk goes down significantly. Yeah, Joel mentioned it in the chat that safety is also related to assessing risk of self-harm and suicidality, which we screen for at time of intake, and youth who are at higher risk, whether that be a previous attempt or going through additional stressors for other things going on in their personal life. We do screenings with that. And again, building that relationship so that youth can trust us to share how they're feeling or what they're going through so that we can get them connected to the right support.
And we have seen an increase in youth disclosing suicidal ideation, most recently this past year. We do have a very specific protocol put into place. We use an evidence-based tool to assess for suicidality and self-harm. We have a very clear safety plan that we review with the parent and caregiver, and then we also do facilitate warm handoffs back to the emergency department for an emergent psychiatric evaluation or to the Philadelphia Crisis Response Center. The second core component of VIP is our trauma-informed mental health services. And this includes our trauma-focused cognitive behavioral therapy, our children and family traumatic stress intervention, which is CFTSI, and our peer-led psychoeducation group called BRAVE, which is building resilience after a violent event. So we're going to talk about all three of those interventions. But before we do that, I think it's really important to talk about why we integrated mental health and case management. The influence of trauma on the factors that our youth and families struggle with, both before and after a violent injury, strongly suggests the need to integrate behavioral health treatment and case management services. So if we can help someone better cope with and manage post-traumatic stress symptoms following a violent event, these being symptoms such as hypervigilance or hyperarousal, we may create a ripple effect whereby we are seeing decreases in retaliatory behaviors and cognitions in our youth and family. Thus, the need for intensive long-term case management services may be decreased for one particular family. So the integration of two services is meant to hasten the journey out of crisis that our clients and their families are experiencing when we first make contact with them. And I'd like to say that the formalized mental health services that we provide is really speaks to that integration, but that psychoeducation that we provide throughout our the entire journey of the families and youth and families with us is really part of that mental health as well. For those of us who know mental health services, psychoeducation is a huge part of trauma-focused work. And so even if they aren't formally engaged in therapy with our program, that psychoeducation piece they still get. So we know that many of our youth and families deal with many barriers to accessing mental health treatment in the community. And so these are a few of the reoccurring obstacles that we were seeing as service providers that made the case for integrating behavioral health services and intensive case management services with VIP. So most agencies have wait lists of several months before the next intake, and then they might still have to wait longer for an opening for a therapist. Right now in Philadelphia, the need for mental health services is very vast. And so we're seeing wait lists of 20 to 25 kids, 3 to 6 months for our kids to get connected to treatment and to therapy. There's a stigma, so there is distrust and negative reputations of systems, as well as a negative outlook on participation or cooperation with various systems among the populations that we support. We know that at times insurance can be a barrier, actually, especially with private insurance, so most of which is not accepted in community agencies. And then these families can't afford to pay out of pocket or even a sliding scale. And then this can prevent an additional financial stress while therapeutic needs go unaddressed. We talked a lot about how transportation is a barrier, and not all agencies provide transportation assistance for mental health. If they do, it's maybe likely 2 tokens, which might not cover transfers or both ways, might not cover other family members that need to come to the appointment because of lack of childcare. We know that our youth and families often have difficulty with trust and being open to help within systems for various reasons, such as prior negative experience, meaning that they have to go through multiple referrals. So they might have to go somewhere new and explain their situation and again, build a strong relationship. This also is a result of high turnover rate in some community-facing agencies where they may see 2 or 3 therapists within their time with one agency, and again, feel like they have to build that trust again and retell their story again, and then being let down by other systems in the past. While trauma therapy services are becoming more common, there is still only a few agencies that provide evidence-based trauma treatment with very fully competent trauma-trained clinicians. And many of these agencies have barriers of their own, like the ones listed above, longer wait lists and stigma. It can also present difficulty for clients to open up and engage in treatment if they feel like they cannot connect to their clinician, or they won't understand them or will judge them. And then lastly, communication can be difficult between agencies. There's often not enough time on either side to fill in about what's going on with the family, playing phone tag, not being aware of crises like suicidality or abuse. We know that a lot of community-facing mental health agencies are fee-for-service. And so a lot of time, those collateral contacts aren't necessarily billable. And so it can present a challenge for us as a case management provider to reach the community provider in order to provide some of that much needed information. And so this was taking up a lot of our time and resources. We were checking in with youth and families frequently while they waited for treatment. We were keeping cases open longer with only mental health being the unmet goal. We were already offering tokens to families or transporting them to sessions so that they could get treatment. We often went to intakes with families so that they would feel more comfortable with an agency and have a warm handoff. And we still do all of this, but we do it a little less because we've integrated mental health therapy into our program. And so, due to the frequency that youth identify mental health needs and the barriers that exist in community-facing programs and community mental health organizations, and the vast needs that families identify after trauma, we did end up embedding trauma therapy into our program in combination with case management services. So this allows us to address the safety and concrete needs while providing psychoeducation around trauma and preparing youth and families for therapy. It helps increase trust when you meet with families where they're at. Many of our families have food insecurity, and if their basic needs aren't being met, then they're not going to be able to engage in therapy. And so there's a case manager, a trauma therapist, and the family on our team, and we all work together to help build resilience and support the recovery process. We also recognize the need for flexibility when delivering evidence-based practices to respect cultural values, changing structure of families, and the need for home-based therapy. So for example, community mental health agencies often have an attendance policy that after a client misses a certain amount of sessions, they are automatically discharged. Well, I understand that because they have long wait lists and they need to engage other youth and families in treatment. What is helpful is integrating it in-house. We are able to have some flexibility with that. So we're able to, it's not necessarily you miss three sessions and you no longer can get treatment. We work with the families to understand what are those barriers, why are you missing these sessions, and then we communicate with the case manager on how to help decrease those barriers. So we create a strengths-based framework that creates a positive experience and empowers youth and caregivers. And we really recognize the tremendous power of what can happen when you highlight capacities and protective factors.
So what does this actually look like in practice? We, as Jackie mentioned, have 2 therapy models that we use that are evidence-based, and one are peer-led group that is informed by evidence and trauma-informed experts. We developed our in-house trauma treatment with the knowledge of the barriers we were seeing with families, with the knowledge about our population, and with the training and resources available to us. So we were all trained through PACS, which is the Philadelphia Alliance of Child Trauma Services. And we had to advocate in order to be trained through that service. We talked about how there were long wait lists, how our youth had recently gone through a potentially traumatic experience, and being able to be trained so that we could facilitate engagement in treatment to get that faster for them, to get that consistent care, since we had our case management services already that we could work together with. And so through that advocacy, we were able to get trained, and this is how we developed our therapy component. And just to know that this is what works for us, but that can look different for other programs and other cities. So like I said, the models are evidence-based or informed by evidence-based practice, which is important. So we know that there is some research showing that these are effective, that they do help with healing, help with support, but it's not the only thing that matters. We also use our clinical experience. And as Jackie mentioned, we take into account individual characteristics, culture, and preferences of our families to tailor each intervention. So we're keeping in mind what the family needs, what the youth needs, and what barriers we may be addressing if we're doing therapy in the home, at their school, at our office, to make sure that it's tailored to each individual. Getting into just a brief overview of the models. The first intervention is the Child and Family Traumatic Stress Intervention, or CFTSI. This is actually a brief intervention. It's only 5 to 7 sessions. It occurs within the first 45 days following a potentially traumatic event. So this is helpful for our youth who we know have just been recently injured. and we're able to provide this intervention. It actually is the youth and the caregiver together in almost all the sessions, with the goal to increase communication, to provide coping skills, to reduce those traumatic stress symptoms that may be going on directly after an injury. And then the second model is trauma-focused cognitive behavioral therapy, or TFCBT. This is a little more well-known model for treating children with experiencing trauma. It's a longer, still short-term, but a little bit longer than CFTSI, with 12 to 25 sessions. It does involve the caregiver, not quite to the same extent. The caregiver is involved in the treatment, ideally as much as possible, but not necessarily in session with the child for each session. And to give a little overview of the curriculum in the next slide, TFCBT is a flexible curriculum. Like I said, we're able to have some flexibility in how we deliver it based on the individual preferences and needs, but it does go through certain components of providing that psychoeducation to families, relaxation and coping skills, affect modulation or feelings identification, cognitive coping, so addressing any thought distortions or negative beliefs that come up related to their trauma, and ends with developing a trauma narrative in some capacity. That can be in a variety of different ways depending on the youth preferences, but some way that they're sharing their experience and often sharing that with their caregiver as well. So we are incorporating the caregiver and also incorporating safety planning throughout the model. And then the last component of our therapy services is our peer-led group, which is called BRAVE, Building Resilience After a Violent Event. We actually developed this curriculum with youth in our program. Like I said, it does incorporate research and information by trauma experts and evidence-based practices, especially some of the TFCBT components that we just went through. And we include that psychoeducation about trauma and about stress throughout the model, and incorporate those coping skills to each session. And I'll get a little bit more into this in a second, but the peer-led model having that power of peer support. So what exactly does our group look like? Like I said, it's led by a peer who's graduated from our program and leads the model, supported by program staff. We do 10 weekly sessions, about 2 hours each. We do it for the older half of our group, 13 to 18 years old, and often divided by age. So maybe 13, 14, 15, whereas 16 to 18, try to separate those age groups. We like to keep it fairly small with 6 to 8 participants, and do close it after a couple sessions to have that trust within the group and consistency. And it's semi-structured with a processing component. So if we go to the next slide, you can see what each group looks like. We have a consistent structure with, again, some flexibility. So each group consists of a check-in, a topic, some psychoeducation related to a topic. We do an activity together, and then have time to process, which may be related to the topic we're discussing, but also flexibility if youth are coming in with a stressful experience from school or a current event, so that we do have space for youth to talk about what they're going through in real time, as well as, the general traumatic experience and healing from that. And then each group, sorry.
Oh, sorry. Go ahead, Jody.
I was just going to say, each group ends with a skill to kind of build their toolbox of coping skills that they can continue to use after the group.
And before Jody talks a little bit about like what the peer mentor program looks like, I also wanted to talk about the same flexibility that we give to CFCBT and CFTSI. We do the same for BRAVE. So one, and the way to reduce barriers, we give transportation to all of the kids that come to group and who they bring, right? So it's not necessarily just VIP youth. They are able to bring a friend, a sibling, anybody that can make them feel a little bit more comfortable in participating in this psychoeducation group, because we know that at times it can be a really big leap for them to open up, to talk about how they're feeling, and do that with a group of kids that they may not know. We do have some parameters around that. And we ask, like, if they're bringing a friend or a sibling, that friend or sibling continues to participate, and that they don't bring like a rotating group of friends or a different sibling each time. Along with transportation, the other thing that we do is we provide food. So we make sure that they have dinner, because we normally meet around like 4:30. To do 4:30 to about 6, depending on the flow of the discussion. And so we make sure that we have not only enough food to feed everybody that is there, but enough food that they can take some home too. So we're never leaving leftovers. We're always encouraging our kids to take the food home to their families. And lastly, part of, and I know people are interested in research and evaluation, we do have a set of measures to study the impact of BRAVE and the curriculum on the PTSS symptoms that our youth may be experiencing. And we also talk about group cohesion and wanting to learn if that peer mentor and peer-led group is something that they found very supportive. In those measures, we actually do compensate our youth for those. So whether it's like a Wawa or a Dunkin' Donuts gift card to complete the measures, or if it's movie tickets, I think that's really important to note, is that we want them to know that we value their input, and we're not just asking them to give us, to take the time to fill out these surveys, because we do know that the population that we work with does disproportionately get asked to participate in research studies and ask for their opinion, with oftentimes not an incentive or not some sort of value or give back. So we found that would be very important when asking our youth to participate in the research and evaluation. Okay. Oh, there it is.
Jackie.
Yep.
So just to give a little more detail about the peer mentor element of the program. So as I mentioned, the peer mentors lead the group with the support of program staff. They are youth who have been through our program, who have graduated, who have been through group before, and have shown leadership qualities to go through training and kind of lead them in this role and new responsibility. So we feel that this benefits both sides, where peer mentors are able to gain leadership skills, job skills, also promote their own healing and being able to share their experience and help others, as well as the participants of being able to have that shared experience with a peer who's close to their age, who's been through what they've been through, and kind of see that hope and future hope. I was just looking at the chat question: program recruitment purely from youth who receive medical services, or do we conduct other outreach? For our program, it is through medical services. So they do need to have received medical care for an injury related to their assault, whether that's through the emergency department or concussion clinic or the trauma unit. So in some capacity, they did receive medical care. Any questions? Sorry.
We are always, while we recognize that can at times be an access issue, we are always looking and evaluating to how to open up our services to more referral sources. And so one of the things that we just did recently was reach out and partner with a local Trauma One hospital that we weren't necessarily seeing the kids that were getting treated at their emergency department, but now have a connection with their social workers so that they can reach out to us when they have a CHOP youth at their emergency department who has been victim of a violent assault.
And before we go, we do have one more topic for our presentation. I'm just looking if there's any other questions related to the therapy services, whether that be the therapy models or our group or peer mentor program. I do see a little more information about the trauma narrative. So that, again, is in the TFCBT model, and that usually consists of the youth talking through in pretty much detail of their trauma experience. So it could be just their assault that brought them to our program, or it could be other events that they've gone through as well in their history, whether that's, other experiences, other losses. So it doesn't have to only be the assault that brought them to the program. And it's the format that the youth chooses. So a lot of times it is sort of making like a chapter book of writing out the experience and talking about their feelings during it, their thoughts during it, and processing that together. But it can take other formats as well, of music or drawing. So that is flexible and open, but does consist of them going into detail about their experience.
I think it's also important to note that we are really thoughtful and make sure that we have a very complete clinical impression on our youth before referring them to in-house therapy. So we want to make sure, like, does the youth need connection to psychiatry? That's not something that we necessarily have consistent access to in-house. So do we need to look at a community provider for that? Do they have a really complex mental health history with a history of depression or anxiety that may be separate from their current trauma? And so it might not, TFCPT or CFTSI might not be the correct intervention for them. And so we may not always look at meeting a therapy goal in-house, because it really depends on the specific need of each child and family. But, and we do that, we collect that information through our intake and through our measures and assessment. And I think the other thing that, just to speak briefly about, is kind of what that staffing structure looks like. So I talked about having like a case manager and a trauma therapist and the family. So we do have a mental health therapist who only sees mental health cases. And then we have a violence prevention specialist who are also trained in these modalities. So they have a great perspective of not only providing intensive case management therapy and knowing that portion of our program, but then also can carry a small caseload of TFCPT or CFTSI. So it provides a very unique perspective on being able to understand both sides of the program. But your trauma therapist is never your case manager. They are always two separate people, so that those lines don't get blurred. Okay. So we would be remiss to not talk about the impact that this work has on our well-being. So the next couple of slides, we're going to talk about the challenges that we face in our work. How do we keep our tanks full? And when it does empty, how can we fill it back up? And not necessarily just relying on the individual to do that, but creating a team culture that promotes that. So there are many challenges that come up with the work that we do. These are just some of them. And so through intake and outreach, we have exposure to upsetting events of personal tragedy. At times, we know what is needed to support our youth and families, but resources or funding that is not there, or there's just not enough. And so additionally, existing systems that in place that should be supportive of our work often place more barriers to the recovery and safety of our clients. We know that there could be conflict among team members when there are a lot of really tough decisions to be made. Not everyone always sees eye to eye. And so we have to recognize that that could be a challenge in our work. When we have high caseloads or there are too many high-risk clients to support, there is often no time to take for self-care, or you're in the field so much and working on supporting these clients that you might get behind on paperwork or admin duties, which can then increase stress. And so, or there is not a sense of psychological safety in the team. And so team members might not feel comfortable sharing the impact that the work is having on them. Or throughout our work with the families, not only at intake or outreach are we being exposed to those personal stories, but throughout our work with our families, we have that continuous exposure to trauma. And so it's important to know that these challenges may and will come up in your work, and how to address them and support the staff appropriately. So due to these challenges and the ongoing exposure to trauma, we also have to be aware of what secondary traumatic stress is. So we know it's defined as the emotional duress that results when an individual is exposed to firsthand trauma experience of another and its symptoms mimic those of post-traumatic stress disorder. And so it's important to understand that anyone and everyone can experience secondary traumatic stress, which is why that we need to be interacting in a trauma-informed way, not only with our patients and families, but also with each other. And so, for example, a physical symptom of secondary traumatic stress might be stomach aches or headaches or increased blood pressure, or you have that kink in your neck that was never really there before, but shows up during stressful times. We may see behavioral changes in ourselves or others, where we might be drinking more alcohol, eating more, sleeping more, having a lack of motivation to engage in things that we know are helpful, like exercise. Our cognition might be impacted, where we could have trouble concentrating. We might be ruminating on certain things, or we might have intrusive thoughts about our experiences with our family. For emotional, we might be anxious or fearful or sad, and kind of feeling the intensity of these emotions and maybe not understanding where exactly they're coming from. And many of us work with patients struggling with suicidal ideation, as we talked previously, but it's also important to note that a symptom of secondary traumatic stress could be our own suicidal ideation. So this is, again, not something to talk about addressing in your program, but have real concrete strategies to deal with, because it is a very real thing that our program staff can struggle with. So one of the things that we do to combat secondary traumatic stress and the challenges in our work is providing trauma-informed supervision, and that's both individually and in group format. So for us, it's weekly individual supervision, as well as bringing a trauma-informed approach to all of our larger program meetings, so our clinical meeting or our program meeting. And that means encouraging sharing the emotional experience of doing trauma work in a safe and supportive manner, offering the space and time for emotional re-regulation after a difficult encounter. So for example, as a supervisor, I make sure to be aware of when a team member is coming back from an intake or a visit in the community, and making a point to check in. And this isn't necessarily just like stopping by a person's desk. It can be, but more often what I like to do is invite people into my office, give them a quiet space, invite them to take a breath, and just kind of listen to how their encounter went, without judgment, without offering a solution, just allowing them that time to talk about how that impacted their emotional well-being. When we're stressed or overwhelmed, it can be really challenging to keep a trauma-informed perspective. And so trauma-informed supervision also means providing continual guiding case conceptualization and service delivery through a trauma lens. It's better for service delivery and for program staff to understand maybe a barrier to treatment or a non-compliance or a reaction in the form of trauma, because it helps us understand and maybe not necessarily judge or think negatively about any experience that a client might be going through. We also want to normalize any common emotional responses to trauma work, such as some of the things that I talked about in symptoms of secondary traumatic stress. So we want to say, like, these are normal things that can happen when we're dealing with such heavy work. But not only just normalize those responses, but provide concrete suggestions on how to address emotional regulation strategies, and then providing that time to do it. So I can say, like, oh, what would really help your secondary traumatic stress is to exercise more, or take a walk, or make sure during your lunch break you're turning off all your phones. But if I'm not actually providing the time and space for program staff to do that, it's very unlikely that they will. So if they're eating lunch as a supervisor and I said, hey, take the half hour to yourself, walk away from your desk, put your phone on silent. But then if I'm walking up to them while they're eating lunch and saying, hey, do you have an update on that client? That's not really providing that time and space that I'm suggesting they take. And so you want to make sure that programs to work in violence prevention have these built-in protective factors into the foundation, and they'll go a long way in supporting program staff. So we talked about trauma-informed supervision. So you want to make sure that staff members, especially frontline workers, are getting weekly supervision that is high quality and that is predictable. And so, crisis work happens, things come up, our schedules get busy, but supervision should be a priority. And if the regular supervision time that you have with staff doesn't work one week, making sure that there is another time that you're meeting with that staff. So moving around your schedule and making sure that that's a priority. You want to make sure to foster and build peer support. So we have a really intense job, and not everyone outside of the work we do always understands that. So if anything, that's one thing that we all have in common and one thing that we can come together on to support each other. Also, just to go back, when you are meeting with supervisees or in a group, to make sure to give your full and undivided attention. I know nowadays it's very easy to get caught up in multitasking and texting and looking at the phone and checking emails during meetings and supervision. But I promise you that staff will feel that. And it's really important to just focus on your time with them and giving your undivided support. The other thing is that ability to diversify the workload. So not every case requires the same level of intervention, or there might be other things within the program that staff have interested in, like program development or grant writing. And so providing those opportunities, not on top of the workload they already have, but making room within their existing workload for them to take advantage of that. So for example, when a new referral comes in and I'm looking at where to assign that referral, I'm not just looking at the number of cases that each violence prevention specialist have, but I'm looking at what are the risk level of each of those cases, what is the injury that they're working with, and what other things are they doing within the program to support the ongoing violence intervention work. So there's a lot that goes into case assignment. It can't always just be by the numbers. We want to make sure that you're helping staff block out time to get admin and paperwork done. Prior to the pandemic, a large portion of the violence prevention specialist time was in the field and in the community, and transportation to and from visits also takes up time. So maybe there's a work from home day built into their schedule where they can be home and be able to bang out all their paperwork needs or their admin responsibilities, so that is not an added stressor in their lives. And then promoting a positive work environment that's filled with optimism. So not engaging in office gossip, celebrating each other, highlighting each other's big wins and birthdays and celebrations. And by modeling and promoting optimism, we're looking for butterflies is what our team calls wins, like small and little. So, you haven't been able to get a hold of this one youth for a couple of weeks and suddenly you're able to, they picked up your call or they answered your test, like celebrating that small win, or, a bigger win of being able to relocate to another county that they feel safer in, and all of the work that goes behind that. So I think as leaders, it's really important to point out everybody's butterflies, because when you're in it, you often might not see those little things and big things that are accomplished through our work with our kids. And so these are actually some apps that we not only give to our youth and families to use, we also use them. So Headspace, Stop, Breathe, and Think, Calm, Insight Timer, all of those are things that we talk about in our program meetings, in our clinical meetings, about ways to engage in self-care. I know as part of my supervision structure, the first part of supervision is all about the violence prevention specialist. How are you doing? Where's your stress level on a scale of 1 to 10? Okay, if it's, higher than a 5, what are we doing to bring this down? How can I support you? How can I help you? Have you used your Headspace app today? And so really talking about all the different tools that people can use and making sure there's time in your supervision to address that. What we didn't talk about, but what I will briefly mention, is that we also have a Stress Less model, which is a monthly support group that works on addressing, it's a psychoeducation support group that addresses the needs for self-care and making sure that staff are aware of their secondary traumatic stress symptoms. And that is led by program staff. So it's for and led by staff to enable a supportive environment at least once a month for all of us to come together and kind of solely focus on ourselves. Okay, so that actually wraps up our presentation. Are there any questions about, we have about, I think about 10 minutes, any questions about how to support staff through the challenges of our work, or any questions in general about VIP or either of our components? Okay, well, if any questions, a key core, I think, your success if you're taking care of yourself as well. Yes, agreed. It is a very key core component, is taking care of ourselves. So, okay.
Just going to add in that it does, even just having that culture to work in makes a huge difference. It's a lot to do this work. You know, we're working with families during very difficult times, during very stressful times, and get very close with families in doing this work. And so having that trauma-informed supervision, having that culture that it's okay to take care of yourself too, so that you can continue to do this work. It is important and does make it a lot easier to have that support and work with your coworkers to make the work a little easier.
So we have a question about how is the concept of self-care integrated into your client program? We do that a lot through the foundation of psychoeducation, is making sure that they are aware of how the trauma is showing up in their bodies and in their minds and in their health, and then work with them around coping skills. So even if they're not in BRAVE or in TFCPT or CFTSI, we're providing education about different coping skills that can be available to them. And specifically within the BRAVE model, within TFCPT and CFTSI, there is a very heavy focus on understanding how your body and your mind are reacting to the trauma and how to cope with that. And, making coping plans. I can't even count how many times that conversations that our violence prevention specialists have with our youth are solely around coping skills, where our youth are really connected with us and they call and say, hey, I'm really struggling today with such and such. And we say, okay, let's talk about your coping skills. What are the things that you can do to help kind of manage what you're feeling right now? So it's very much integrated into our work. Lots of questions. How long do clients tend to stay in your care, and how do you go about reestablishing connection those initially lost with care? We had how long clients stay in our care. So ideally, like 6 months, we work with clients to get them connected to resources, promote self-efficacy and resilience, and then hopefully after their goals are met, close out. However, we have families that are much more complex that we can be involved with for years. So we don't have a set amount of time. It really is based on the level of complexity and what the client and family need. As far as reestablishing contact with those initially lost, we do have, if there's several weeks or months that goes without contact, we do have like a form letter of loss of contact letter that we send out, letting them know we've been trying to get a hold of them and leaving that door open for them to come back and establish connection with our program. I think prior to the pandemic, we never do kind of pop-up visits. That's just not in our kind of framework, because we're honoring voice and choice. And so if a family isn't talking to us or isn't responding, we take that as that's their choice not to engage in programming anymore. But we also recognize that things and life comes up. And so we might not be a priority right now. And so we leave that door open. That's kind of what that loss of contact letter says, is like, hey, we haven't heard from you in a while, but we're still here and ready to connect when you are. But we're not just going to pop up like some other systems do in their lives, because we want to respect their voice and choice, even if they're not saying it verbally. Yes, we do have regular clinical meetings to discuss clients. We do have weekly supervision as well as a weekly clinical meeting that is multidisciplinary. So it involves not only our frontline workers, but our program leadership and a psychiatrist from our Department of Children and Adolescent Psychiatry at CHOP. And those are weekly for about an hour and a half. Jody, do you want to speak to how we manage distrust and resistance?
So I think as we talked about, we are a voluntary program and we offer support with what the family wants help with. So at the initial intake and outreach with families, we're saying, here's what we can help with, here's what it sounds like maybe going on, here's our experience of what we can do about it. And we kind of find that opportunity to get buy-in. For a lot of our youth, that may be just getting them working papers. For our parents, it may be getting them food, so, or it could be that families are really needing a lot of support and we're saying, you have a lot going on, how can we help you? And they are very accepting of that. I think for families who may be more resistant or hesitant to trust us, we're taking it one step at a time so that we can build that relationship. A lot of our families I've been in long car rides with, going to and from appointments, and that's how we sort of start our relationship. And once they see that I'm showing up like I say I'm going to do, and I do what I say, then we can start to build our relationship and they may be more receptive to, oh, I actually need help with this too, or call me when something comes up that they need support with. So it's just one step at a time of building that relationship and working with the family with what they ask for.
There's a question about hiring process for people besides credentials and experience. So Sherry, I would say our hiring process is pretty detailed. It starts with posting the position and then looking through a plethora of candidates. And then we do some screening questions to start. So we ask about their experience in trauma-informed care. We ask about their experience in community-facing programs and their knowledge of resources. We ask about their lived experience and their comfortability in working in violence prevention. So we have some of those screening questions of like the core values and qualities that we're looking for in hiring someone prior to even interviewing them. And then when they do come in for an interview, it is a multi-process step. So they often meet with maybe program leadership first, and then they meet with our frontline workers first. Our hiring process is really also a collaborative effort. It is not just program leadership making the decision on who to hire. It's really a team effort, and we get opinions and recommendations from all levels of our team, from all arms of our team. So we're looking at leadership, case management, research. Everybody's opinions matter because of how difficult the work is and how much a team environment is needed to continue to do this. I think we're just about at time too.
Perfectly at time. And we really appreciate this preparation and the excellent description of your program, both Jody and Jackie. I thank you so much.